neonatal transport systems began in the early 1900s, and they evolved from horse-drawn vehicles, carts, to old-type style ambulance, to regular ambulances, and then to specialized ambulances today that transport the patients. At the time that I came to Stanford essentially in 1970, the patients were being transported in battery-powered, I call them lunch boxes. They were just a little container. If you opened the container with the window, then the heat would come out, and you also couldn't provide intensive care. You couldn't ventilate them through these units. Essentially, you just put the patient in a little box, and then you transported them. And they were being transported up to 2.5 and 3 hours to our place. And so that's what we had when we arrived. Well, the first challenge was that there was no specialized care for these babies. In the 1950s, Dr. Usher in Canada demonstrated that with what he showed was that babies that were born in regional care centers did better than babies that were delivered in community hospitals. And the linkage had to do with how they were cared for during transport, how they were resuscitated and cared for. So we had to develop the whole field, frankly. And in the operating room, once again, there was no focus on pediatric care. That is, anesthesiologists would take care of all types of patients, including in the cardiac surgery group. And so we had to essentially alert and teach anesthesiologists and surgeons that there was a difference in the type of care that was required for infants and children and then adults. And then we had to show that physicians and nurses who cared for those patients could provide better care, and there would be better outcomes. So it was really starting from scratch. When I came to Stanford, my work centered in several areas. I was responsible for the assisted ventilation that neonates got in the neonatal intensive care unit. I had been preceded by Dr. Vern Thomas and Penelope Smith, who did pioneering work in the treatment of RDS with assisted ventilation. So I continued on in that work. And at the same time, I started doing anesthesia for pediatric cardiac surgery patients with Dr. Shumway. And then I started to link the two experiences because at that time, the postoperative intensive care for the pediatric patients was not focal, if you will. It was not specialized. It was part of the general intensive care. Having the experience with the neonatal patients in the intensive care unit, I combined them, and I was on the faculty in both anesthesia and pediatrics. And then it became apparent that the patients that were coming in what I considered to be very antiquated equipment. They were being transported from patients and other hospitals for care, specialized care, but by the time they got to us, they were hypothermic, they were acidotic, and so something needed to be done about that. So with associates, including Professor of Mechanical Engineering in the Thermal Sciences Division, we began working on equipment that would keep the babies warm during transport. We devised a whole new system. We devised a system that was radiant heat that allowed the canopy to be, the top of the unit to be rolled back to whatever level you wanted, and allowed us to provide intensive care to get to the patient in a heated environment. We also developed a new oxygen system, a liquid oxygen system, which was lightweight. We developed new monitors, etc. So we developed a completely new package for transporting the patients. We began working on a communication system that would bring the hospitals together, that allow the physicians and nurses to talk to each other. And we began working on many other facets of the transport program, really trying to make the patients, when they arrived at the regional center, in better clinical condition, thus allowing us to care for the patients in a better manner. And as we've learned more about the care of critically ill infants and older patients, we've realized the importance of fluid management as well as temperature regulation and as well as assisted ventilation. So now we're able to provide the type of care that you would within a given hospital when you're transporting a patient. We're able to provide it outside of the hospital. And the whole idea was to develop a continuity of care of the highest quality from the time that the patient actually was delivered, if you will, to the time that they came to us and received care. So we not only do we move the transport back, but we moved resuscitation forward in the referral hospital, and we actually got state requirements for newborn care units, okay, in community hospitals that requires every hospital to have a resuscitation team and those patients and be able to care for the baby until a transport team arrives. So we moved the whole system from beginning to end forward. From that evolved a transport system that became a model, and then today is now called the California Perinatal Transport System, which is sponsored by the state of California, and which includes many different facets of the program. We do 7,000 cases throughout California of neonates in each year. Not just to Stanford, but actually to 130 NICUs in California.